Thank you so much for that kind introduction. It's so nice to spend quality time with 2,000 plus of my closest friends, or whatever we're up to on the attendee list. My name is Mark Donaldson, and as I said, for Thursday night, this is a great way to sit back, relax, enjoy some CE in the comfort of your own space, and hopefully get a lot of your questions answered tonight. Where I'm coming from to you virtually tonight is actually from my home in Whitefish, Montana. Looks very similar to this picture that you see here, although we do certainly have a lot more snow on the ski hill back there. But I'll highlight a little bit of that as we go along. Hopefully you're at the right continuing education event. So we're going to be talking about postoperative analgesia tonight, and that most excellent or perfect postoperative recipe that will get 95+% of your patients out of pain without using a narcotic. We will certainly talk about opioids, narcotic prescribing, and really wrap everything up in a nice bow by the end of our time together. But our emphasis is certainly going to be on the best medications to manage orofacial pain. And of course, we want to do that as safely as possible, which means not starting with narcotics or opioids up front. I would be remiss if I did not, again, thank Premier for putting this all together, bringing us together, and allowing us an evening of continuing education. Probably the most important thing on this particular slide is my email address. Please take advantage of that. I see from the attendee list, I've got some of my Canadian colleagues here. I've got a number of people from across the United States, as well as other parts of the world. So it's amazing to be able to reach out from my office to where everybody else is on the globe. And again, utilize my email address if you do have any questions outside of this course. I certainly throw that open to any attendees at any of my presentations. And I still have people from courses 15, 20 years ago who will email me and say, Mark, I've got Mrs. Smith in the chair, and this is our planned operative. Any questions or hints that you could offer, and I'd be more than happy to weigh in on those. I do try to return all of my emails within 24 hours unless I'm traveling, but hopefully this will be either the continuation or the start of a long-term relationship. Just a couple of quick disclosures for me. First of all, this is kind of a more recent headshot that you see here. I'm probably similar to many of my colleagues on the phone, and I'm talking primarily to the males who took advantage of the COVID season and grew a beard. So I did that, but my wife really didn't like it. This is what my old headshot looked like, which is just kind of so hard to look at. So we've got the newer headshot now too. Couple of my disclosures: I do walk the walk as well as talk the talk, which means that not only do I do research, teach, and publish in the area of dental pharmacology, but I also work full-time as a clinician. And so, I think that the information that you're going to get tonight is not only going to be topical, it's not only going to be evidence-based, but I think most importantly, and the reason any of us go to continuing education, is that you will get some salient information that you can actually implement at chairside the next time you're back in the office. If that's tomorrow, fantastic. If it's not until Monday and you're taking a long weekend, even better. But you will definitely learn some additional tools tonight that will make you a much better prescriber, and most importantly, get your patients out of pain very rapidly. Taking you back to where I live in the northwest corner of Montana here, we're about 15 miles from Glacier National Park. You can see that's a early shot in the fall of what the location of our mountain is to our little town here. It takes about 15 minutes from downtown to get to the top of the ski hill. And for my skiing colleagues out there, last year we had over 17 feet of base. So certainly a great place to come and strap on those boards and ski down that hill. My last disclosure slide, just to let you know that I do monitor a number of dental pharmacology listservs. I do serve on the editorial board for the Journal of the American Dental Association as the only non-dentist, a role that I'm very proud of for almost 11 years now. And I do act as a referee for a number of journals, not only in the dental literature, but also in the medical and pharmacologic literature. But with that, my last quick shot of Whitefish, just to give you a sense as to what we're looking at right now. I woke up this morning and it was just barely above 10 degrees with some fresh snow. So it should be another great skiing season, as well as hopefully a good couple runs this weekend. Okay, so no particular disclosures. If I happen to mention any company or product, it's only because they have an excellent reputation, or they're linked to some positive information in the evidence-based guidelines that are out there. But I certainly do not accept any remuneration from any of the companies or products that may be represented today. Because this is pure continuing education, it's important to remember that we have learning objectives. I won't read through these, but they are in your handout for completeness. Now, a quick note about the handout. There should be a link in the chat. If you have not already downloaded the handout, I would suggest you do that. It's nice to follow along, plus it is a labor of love. I probably spend more time on the handout than I do on the actual slides. And there's a couple of reasons for that. One is that I want this to hopefully be the one handout that you don't throw away. It's actually written not so much as 3 little PowerPoint slides and then a bunch of blank lines that you might write your grocery list on, but it's actually written in more of a prose format, fully referenced, that you can go back to anytime. Now, I do know that for some of you, it's late on a Thursday. You've probably put in a big day at the office, and sitting down listening to me for a couple hours. It may take a little bit of intense concentration. And if you happen to find yourself concentrating with your eyes closed, if you happen to open them and feel a little disoriented, one of the important pieces on my handout is the fact that every single word from all of my slides are already in front of you. And if you do happen to feel a little disoriented, all you have to do is take a look at the slide. You'll see a little placard like this that has the page number, and that will tell you exactly where you are in the handout. So I've really tried to make this as palatable as possible. I really do want you to sit back, relax, enjoy the handout, follow along, but hopefully there shouldn't be a lot of questions, because everything that you're about to see is contained in the handout right in front of you. But I do certainly look forward to any type of discourse at the end. All right, so this is a great springboard, if you will. It's a slide that I often use whenever I'm talking to dental professionals. And it's taken from Dr. Burkett's oral medicine textbook. Many of you on the East Coast probably recognize this as one of the Bibles within your dental education. And part of the reason I use this as a springboard is because Dr. Burkett and his colleagues distilled basically everything that you want to consider anytime you step into the office to treat a patient, down to 4 questions, 4 sort of internal questions that you want to just run through your brain, almost like a checklist to gauge whether or not there's something you might want to do differently in order to not only keep your patient safe, but be able to treat them effectively. So part of the reason we're talking tonight is because that very first one is around about pain. In other words, based on the patient in front of you, do you have the tools, the knowledge, the skill, the prescriptions to get that patient out of pain? Now, we will mention a little bit about local anesthesia and being able to offer excellent intraoperative local anesthesia, but we also do want to focus on when the patient leaves our office and that local anesthesia wears off. What is your opportunity for providing excellent postoperative analgesia? And again, I will share with you those recipes and a few variations to really maximize the medications that we have out there. While we're not covering it tonight, I think it's just important for completeness to go through the other sort of 3 check boxes that you want to run through your mind. One is roundabout bleeding. We certainly have a number of patients, certainly as our patient population gets older, on anticoagulants and antiplatelet agents. And if you're going to go below the gum line and cause bleeding, how can you be sure that you're going to get good hemostasis postoperatively? If you feel unprepared for that, then maybe that's not a box you're able to check off. If you feel well armed with the different manipulations, tools, as well as pharmacological agents, then that's the second box you'll be able to check off. The next one speaks a lot to this pill-popping society, whether we're in Canada, the US, or many other countries where we see a significant reliance on pharmaceutical agents. And so this patient coming into your office today who may already be on 5, 10, 15, 20 drugs, if you are going to be using any type of medication, are you going to make a bad situation worse? Could you in fact induce any type of drug interaction? Do you have a repository, an app on your phone, a book on the shelf to go to make sure that the drugs that you use will not interact negatively with the medications the patient's already on? Hopefully the answer there is yes, and you can check off that box. The final one has to do with infection. In other words, can the patient in front of you mount an appropriate immune response based on either their underlying medical conditions or based on the type of dental surgery that you may be providing? If you feel very well armed in understanding exactly what antibiotics may be appropriate for the patient in front of you, that's excellent. And I'll make it very simple because there are only 3 pure indications for you to be writing for any antibiotic. There are 2 prophylactic indications. So either patients with very specific cardiac history, and there's only 4 indications within that cardiac prevention, or is this a patient that cannot mount an appropriate immune response? In other words, they have some measure of immunosuppression, and we want to prophylax for that. So out of the 3 appropriate indications for antibiotics roundabout dentistry, 2 are the prophylactic ones I mentioned, and then the 3rd is the treatment indication for somebody that actually has an active orofacial infection. If you are ever considering antibiotics for a patient outside of those 3 indications, you may be outside of current guidelines, and I would suggest that you get some additional education or ask me, and I'm more than happy to send you updated guidelines roundabout antibiotic prescribing in dentistry. So what does Dr. Burkett and his team do with this checklist? Well, this mental checklist, if you can go through this prior to seeing any patient, it can be your opportunity to deselect patients. If you don't feel comfortable in your ability to manage that patient's pain, bleeding, drug interactions, or infection, then maybe today is not the day you treat that patient, or maybe your office is not the best place for that patient to be treated. And so that's a nice way to mitigate risk. If you are able to check off all 4 of those boxes, then you get the green light. And that means that you're going to go forward to treat the patient using the best available evidence, and you have mitigated any potential risk prior to introducing any type of surgical technique. So again, I like this. We have several slides where I may suggest, taking that mental snapshot. This is definitely one of those, and I think it helps to guide contemporary dental practice. Okay, so hopefully with that brief introduction, everybody is strapped in, got your beverages or snacks all set to go, and we can enjoy some dental pharmacology together. Okay, well, if that played well for you, I showed that to my kids who are in their 20s, and they said they didn't get it. I tried to explain that, we used to have typewriters and what those are. The fact that I graduated after the internet amazes my kids. I'm sorry, before the internet amazes my kids. They kind of wonder, how did we ever learn anything before the internet? Okay, so analgesia, post-operative analgesia for our dental patients. Prior to starting any of these particular talks, I do want to remind you that it's on you to update and read your regulations. Regulations do change, but understand that whether we're in Canada and looking at our college, or whether we're in the United States and looking at the state dental boards, they are the ones that make the rules. They are the ones that give you the license to practice. And so if they change those rules, you need to be up to date with them. So we will refer back to the different regulations that may be out there that are guiding current contemporary dental practice, especially as it relates to the prescribing of analgesics. Here's just one example. I have several others, but in California, we see that recently there has been a mandated course in opioid prescribing, which is just one of the continuing education requirement changes for 2023. I just simply pulled out California, but I can tell you that almost all other dental boards in the United States, as well as many of the colleges in Canada, and I'm sure in other countries that are on the phone today, are probably in the same boat of encouraging and in some cases actually requiring a certain number of hours in continuing education roundabout appropriate analgesic prescribing. So for that reason, I'm really glad that you're spending time with me tonight. You'll get at least 2 hours of credit towards that particular mandate. Another regulatory example here, again, bringing to light and actually defining, in this case, that you must complete a one-time continuing education course that is at least 3 hours in length. And so while not all states and provinces are requiring a total of 3 hours on post-operative analgesic prescribing, that's probably close to the average. I've seen 2 hours required, 3 hours required, in some cases 4 hours required. So Again, you want to be up to date with your regulations and understand what it is that's required in order to maintain your licensure and play amongst the rules. The great thing is that the boards aren't just dictating that you must follow these new rules and regulations. They actually do try to help you as much as possible. Here, for example, is the Washington State Department of Health website, and you can see as far as opioid prescribing and helping to address the opioid crisis through prescribing and monitoring changes. There are in fact tools that for prescribers or for practitioners button that I've highlighted allows practitioners in Washington State to access tools in order to help them achieve the appropriate training in managing patients postoperatively. They also link to the toolkits as well as providing additional information. And this is just one example. As I said, most dental boards have provided this type of data, these types of tools for their population. Texas, again, just randomly selecting a couple screenshots from different dental boards. You can see here a strong focus on helping to end the opioid crisis. We'll talk at the end of this session around about prescription monitoring programs, or PMPs, which in almost all cases are required for you to access if you are considering writing for any type of controlled substance, to include opioid analgesics for postoperative dental pain. So just kind of a highlight of what we're going to be touching upon this evening. Now, if you didn't want to stay for the full program, everything you need to know about medicine is in this singular slide. In 2000 BC, we were told to eat this root. 1,000 years later, we were told that root is heathen, say this prayer. In the 1850s, we recognized that prayer is superstition. We should drink this potion. In the 1930s, that potion was recognized to be snake oil. We were told to swallow this pill. In the 70s, we recognized that the pill is ineffective. Take this antibiotic. And here we are, 2023 and beyond. That antibiotic is artificial. Eat this root. So I always start my my lectures around about pain management with a slide similar to this, because even though we've had such tremendous advances in technologies, in surgical approaches, in pharmaceutics to manage pain, we still don't have that panacea, that magic bullet, that one drug that works well in all patients all the time. And part of the reason for that is because of the definition of pain. And as you know, the definition of pain is whatever the patient says it is, which means that for every iteration of patients out there, we have every iteration of a possible definition. And that's why the management of postoperative dental pain in particular is a significant challenge, because not all of our patients are created equally. Again, I promised you that at the end of this session, I will give you the tools, the recipes, if you will, that will help to get almost all of your patients out of pain. You will be able to customize those and in most cases not have to rely on opioids or narcotic analgesics. As we take a look to sort of frame our discussion, pain has many different formats. Obviously, when we start to talk about orofacial pain of a dental nature, we're really talking about acute pain, localized pain, short-lived pain. But many of our patients may have chronic pain. They may have neuropathic pain. And this orofacial, this acute pain is now sort of on top of that, making it a much more challenging mixed pain profile to treat. In fact, studies have shown that about 3 to 4 types of pain per year are experienced by both North Americans. That would be our Canadian colleagues as well as American colleagues in this data. You can see that the annual cost, and this is American figures at the bottom, from one of the most recent articles that I could find at the American Academy of Pain Medicine, showed that in 2021, the cost in managing pain in this country was about $356 billion with a B dollars. Over 50 million in the United States are partially or totally disabled by pain. So it's important for us to understand pain, recognize it, and then most importantly, what are the goals? How can we manage it? In many cases, we certainly want to eliminate pain. And as we talk more specifically about orofacial pain associated with dentistry, that acute pain, patients can point to when it started, and hopefully you can get them out of pain and they'll be able to point to when it stopped. But if we do have some of those more challenging individuals with neuropathic or oncolytic pain, with a mixed sort of pain profile, this acute dental pain on top of that, in some cases, we may not be able to actually cure them. It may be simply more the ability to manage those individuals and and hopefully return them to their ADLs or activities of daily living. In fact, one of the sort of simple schematics that we have historically utilized for introducing pain are these two general buckets: acute pain, which again patients can point to. They can tell you, I have pain right here. It's localized. It's usually short-lived. They can sometimes even tell you what caused it, and if we can remove that infringement, then we can get our patients out of pain. So acute pain does tend to be curative, and in most cases, as we talk about orofacial pain, that is exactly what our goal is. However, if we consider other patients that have, some type of chronic pain, and in the image you see here, this could be your parent or grandparent with some type of inflammatory arthropathy, such as rheumatoid arthritis, where over time you start to see breakdown of function and the inability for these patients to, let's say, feed themselves, dress themselves, toilet themselves, and be in chronic pain throughout the course of every day. In these patients, unfortunately, certainly if they have a dental component on top, while we might be able to help with the dental pain, the acute pain, we may not necessarily be able to cure that chronic pain symptom. And so those types of syndromes, oftentimes, as I said, our goals may be more rehabilitative in nature rather than curative. We have a thing called the opioid crisis. And in fact, if you watch the State of the Union address by our sitting president just a few days ago, even he referred to the opioid crisis. So it's not a new thing. It's also not necessarily restricted to the United States. Again, my colleagues in Canada are going to get drawn into this as well, and I'll show you some statistics that highlight that. But dentists certainly can play a role in helping to manage or even curb the opioid crisis. So let's frame our discussion here, and I'll start with a fairly recent Associated Press quote. This was a White House official who declared the opioid epidemic a national public health emergency. And in fact, the quote here says, "Nobody has seen anything like what is going on now." Again, that was back in 2017, but believe it or not, if you take a look at earlier Associated Press quotes, again from U.S. health officials back in 2011, so almost 6 or 7 years prior, the number of overdose deaths from painkillers more than tripled over a decade, a trend that U.S. health official called an epidemic. So the idea of an opioid epidemic is certainly nothing new to us. As I mentioned just in the last week, it was brought up at the State of the Union address. You see the quote from 2017, which was even preceded by a quote from 2011. So unfortunately, I think that we are all very conscious of this opioid epidemic, and as healthcare providers, even more conscious about not contributing to it, but in fact hoping to reverse that course. If you take a look at some of the headlines in papers from USA Today, you can see that when painkillers kill 2 people every hour, it's time to act. And when this publication first came out, at that point in time, we were seeing over 18,000 deaths per year, 40 patients per hour going to the emergency department, resulting in over 350,000 visits to the hospital every year due to this opioid epidemic, at least in the United States. One of the trends that we have seen, and we'll talk more about this on page 11 when we get to that in the handout, but drawing in dentists, should naloxone, the reversal agent for narcotics, be considered part of the minimal dental emergency kit? And that certainly has been raised. You can see there was a publication in General Dentistry just within the last couple of years on that very topic. I will give you the answer at the end of the presentation. But just understand that dentists certainly do have a role to play in managing the opioid epidemic. Now, is it all about narcotics? Well, when we talk about the war on drugs, which was a term coined originally by President Ronald Reagan back in the 1980s, that was the war on illicit drugs. And while it hasn't necessarily gone away, the new war on drugs is in fact the war on prescription medications. What this slide shows, work done by the University of Michigan, taking a look at prescription and over-the-counter medications, which accounted for 8 out of 13 of the most frequently abused drugs in one of our youngest populations. These were 12th graders here in the United States who admitted to utilizing drugs, illicit and prescription medications in the prior year. And what's amazing about this, first of all, we can see with the deregulation of marijuana in both of our countries, that marijuana continues to have the highest implication. But as you look across these bars, all of the ones that show up in red are in fact prescription drugs. So while the war on illicit drugs hasn't necessarily gone away, the rise of this new war on drugs, which is people accessing prescription medications and abusing those, is sort of our latest and greatest concern, especially in some of our youngest patients. Now, there's a couple thoughts here, and that is, if people are not breaking into pharmacies and hospitals to steal these prescription medications, how in fact are they getting access to them in order to abuse them? And that's typically one of two ways. They are either taking them from their parents or grandparents or family members who may have legitimate prescriptions for these, or they are getting them from the prescriptions that you write. And I'm not just singling out my oral healthcare professional colleagues, but medical colleagues as well are in the same boat. So every time we're about to write a prescription for a controlled substance or a potential substance of abuse, recognize that that could be a conduit for somebody to access those drugs. And that's very powerful when you start to think about that. As I mentioned, this is not the opioid crisis, just a United States phenomenon. In fact, one of the provinces up in Canada, British Columbia, showed that the number of pharmaceutical opioid-related deaths exceed the number of deaths from motor vehicle accidents involving alcohol in British Columbia. So certainly, Canada and the U.S. bear a large presence, footprint within the opioid crisis. But other countries are affected by it. Unfortunately, not to the same degree. And so when we talk about the prescription opioid abuse, number one is the U.S., two is Canada, and then way down below that, number three is actually Germany, and then other countries will follow suit. But the two largest offenders do happen to be us here in North America. And then I thought that this was interesting, bringing us much closer to modern day. National Public Radio released just last year that for the first time ever, the United States will top 100,000 opioid overdose deaths in a single 12-month period. Now, you have to read this quote a couple times because the reason that it's so important is we have seen a number of opioid-related deaths, months over month, but this was the first time ever that for 12 consecutive months, it had been such a significant issue. And so unfortunately, the opioid epidemic is still amongst us and does not seem to be going away anytime quickly. In fact, from a dental perspective, you can see that in your journal here in the United States, the Journal of the American Dental Association, the opioid crisis garnered at least 3 cover stories in 1 year. And the intention, of course, is to not only raise awareness amongst prescribers, but also to offer opportunity for alternatives and to not add to the current burden on our society. So this is it. You have skin in the game. In fact, dentists follow primary care physicians as the second leading prescribers of immediate release opioids. And so it's been well documented and published in the peer-reviewed literature that as such, dentists have been identified as having an important role in opioid abuse prevention efforts. So I really appreciate you spending time with me tonight, not just to learn how to avoid this, but perhaps how to do a better job of helping manage this opioid epidemic that we framed up. So let's talk specifically about pain management, especially as it relates to oral facial pain or pain of a odontological origin, and what should we be doing, and what should we perhaps stay away from, and what really has percolated to the top as perhaps the best drug or best combination of drugs in helping get our patients out of pain and keep them out of pain. Well, I think we can do better than the cavemen. This says, do you think I should give him 50 or 100? 50 is the small bat, 100 is the big bat. And there's always some truth to this in medicine because oftentimes we think more is better, bigger is best. If a little bit works, then more might work better. And in some cases, that's true, but not always. And certainly in the case of analgesics, while a little is often effective in patients, as you start to push the doses of analgesics, that risk versus benefit starts to change. And a lot of the drugs we're about to talk about do have maximum recommended daily doses for a reason. So we certainly don't want to exceed those MRDs, those maximum recommended doses, as we start to introduce medication to our patients. There are certainly many pain management options out there because, as I said from the very beginning, the definition of pain is whatever the patient says it is. So for the multitude of definitions that we have, we need a multitude of solutions. Certainly there are physical interventions, whether that's counterstimulation, exercise, TENS, even acupuncture. A lot of great peer-reviewed data out there showing that acupuncture is in fact quite effective in managing patients' pain. Psychological techniques, whether that's relaxation techniques, whether it's meditation, support groups, all of those types of things, all very, very important, because in managing some of our more complex chronic pain syndromes, oftentimes it is a multimodal approach. Perhaps being the only pharmacist on the call tonight, it may sound strange coming from me saying that, it's not all about the drugs. Certainly the medication helps, but a lot of these other interventions in combination with pharmacological interventions tends to be the greatest success. In other words, again, a multimodal approach. Given our limited time tonight together, we will focus on this last bucket, which really are the non-pharmacological interventions. In other words, if we go below the gum line, if we cause pain in the patient here, how can we make sure that we administer medication that addresses exactly where that pain is? Starting with local anesthesia, of course, and then managing our patients with post-operative medications that will target peripheral pain where we have caused or where the patient has pain. So why is this important? Well, again, we're going to keep bringing it back to this baseline of regulatory issues, because prescribing appropriate post-operative analgesics certainly has risen to the level of the regulatory authorities, such that they are now embedding it into regulations. You can see here again from this regulatory example, it's written right into the regulations that as part of your treatment plan, acute non-operative pain and acute perioperative pain should include non-opioid analgesics as the first line of pain control. So very interesting. I don't think that dental boards and colleges were as prescriptive as this in the past, but certainly many of them are now starting to tell you exactly which drugs you need to use for which diagnoses as first-line agents. What are some of the drugs that we're going to be talking about then? Well, for the over-the-counter or peripheral analgesics, like most medications in our cabinet, drugs tend to have at least two names. So they have their brand name or names, as you can see, and they have their generic name. So starting at the top in the generic side, acetaminophen, most of us know as Tylenol. Aspirin comes as various brand names. Ibuprofen can also be recognized as Advil, Motrin, and Nuprin, and so on. What is the teaching point with this particular slide? Well, our patients don't necessarily speak our language. And so if half of the recipe that I'm going to give you tonight is to prescribe maximum daily doses of ibuprofen for your patient, you need to make sure that the patient takes the prescription that you provide, but that they don't go home and augment that maximum recommended daily dose of ibuprofen with some Advil or Motrin or Nuprin that they may have at home. I'll do what that dentist says, but the only thing that really works for me is Nuprin. So I'll take the maximum ibuprofen daily dose that he's suggesting, but I'll also augment that with my Nuprin. Patients don't recognize that all of those are the exact same drug. The active ingredient in every single one of those is ibuprofen, and very quickly they can get above the maximum recommended daily dose, which can lead to some very negative side effects. The bottom of our list here starts to introduce some of those more central analgesics. These may be the ones that we reach for only after all other options have been exhausted. And we'll talk more about that at the end, but these tend to be our narcotics. And as more and more information is brought to light about the side effects and adverse reactions associated with these opioid-based analgesics, you're going to see access to them being removed. In fact, propoxyphene, also known as Darvon, was removed from the American Pharmacopoeia back in 2010. There is, in fact, a group known as the Beers Group, that's BEERS, who makes a petition to the Food and Drug Administration in this country every year with new evidence pointing to medications, typically older medications, where that safety versus benefit profile has shifted. And it's oftentimes the Beers recommendation to the Food and Drug Administration to deregulate or remove drugs from the American Pharmacopoeia that leads to this limiting access. Don't be too surprised if in the next few years others on this list, pentazocine, meperidine, also get removed from the American Pharmacopoeia, because again, the benefit no longer outweighs the risk of utilizing these in many patients. So the most ubiquitous analgesic of all is acetaminophen. We'll talk quite a bit about acetaminophen just because of that ubiquitous nature. I think it's part of our natural lexicon. In fact, we hardly ever talk about acetaminophen. We probably refer to it as Tylenol in very similar ways that we talk about tissues as being Kleenex. We hardly make a differentiation between the brand and generic. It's just part of our daily lexicon. Well, acetaminophen is comparable to acetylsalicylic acid or aspirin, also known as ASA, as well as our other non-steroidal anti-inflammatory drugs, or NSAIDs, in regards to its analgesic and antipyretic activities. In fact, a phenomenal medication that's been around for a lot of years, as we'll touch upon. But acetaminophen is only going to make up 1/2 of the analgesic recipe that we're going to build towards, because unfortunately it has a weak anti-inflammatory activity. Now, if you remember, pain secondary to dentistry is typically due to inflammation. And as a weak anti-inflammatory agent, acetaminophen in and of itself is probably not going to be the drug of choice for postoperative dental pain. It's going to be used in combination with something else, and that something else is usually a non-steroidal anti-inflammatory drug, something like ibuprofen. Acetaminophen does have a minimal antiplatelet effect, however, which makes it very popular. In other words, if you go below the gum line and cause bleeding, because it does not cause the same type of hypoprothrombanemic effect as our non-steroidal anti-inflammatory drugs, it's very useful as an analgesic tool, because while it helps to get our patients out of pain, it doesn't cause increased bleeding or decreased wound healing postoperatively. Now, we used to tell patients, so that's past tense, we used to tell patients that if your tummy gets upset with non-steroidal anti-inflammatory drugs, that acetaminophen is gentler on the stomach, and maybe that's a better choice for you. In other words, we have always believed that acetaminophen causes minimal injury to the gastric mucosa. And while in general that has been true, there is some new epidemiological evidence that I'll share with you that shows that acetaminophen is not necessarily completely innocuous. So it may be safer, or it may be gentler on the stomach, but it still has the propensity to cause peptic ulcerations and bleeds. A regular strength Tylenol contains 325 milligrams of acetaminophen. An extra strength Tylenol contains 500 milligrams of acetaminophen. And the typical dose that we prescribe our patients is anywhere from 325 to 1,000 milligrams 3 to 4 times a day. What is most important on this slide, however, is to recognize that as of today, 2023, the maximum recommended daily dose of acetaminophen from all sources is still 4,000 milligrams, in other words, 4 grams. So it's very easy to get to that if you give a patient 2 extra strength Tylenol. They're 500 milligrams each, so 2 of them equals 1 gram. And they take those 2 extra strength Tylenol every 6 hours. That will be 4 times a day. 4 times 1 gram gets you to that 4 grams. So getting to the maximum recommended daily dose of acetaminophen for right now is 4,000 milligrams from all sources. It's actually fairly easy. And so it's not hard to see how some patients may get over that maximum recommended daily dose if they're taking acetaminophen from multiple sources, as we will talk about. If patients happen to have some underlying type of hepatotoxicity, in other words, they have a history of drug abuse or alcohol abuse or hepatitis, where their liver just does not work as efficiently as you and I, then that maximum recommended daily dose actually gets dropped to half. In other words, those patients should not exceed 2,000 milligrams of acetaminophen from all sources in a 24-hour period. The reason I'm really emphasizing this quite strongly is because a lot of people don't realize that acetaminophen is the leading cause of liver transplantations in this country as well as in the United Kingdom. And it's because it is the drug of choice for many inflammatory arthropathies. So imagine your parent or grandparent that has rheumatoid arthritis, as a standard of care, is taking 4,000 milligrams of acetaminophen every day for their rheumatoid arthritis. As they get older, if they have some type of cognitive impairment, and I don't know if you've ever tried to do something 4 times a day, every day for the rest of your life, you probably get to a point where, I can't remember if I took that dose. I'll just take another. It's only acetaminophen. I don't remember if I took my last dose. I'll just take another. It's only acetaminophen. And so you can see how very quickly, certainly in our older patients that are taking maximum recommended daily dose of acetaminophen, how quickly they can perhaps get above that maximum recommended daily dose, leading to ascites, fulminant liver failure, and at their age, they probably will not make the transplant list. In fact, there was a recent editorial in the New England Journal of Medicine that said if acetaminophen came to market today, it would be a prescription drug. But just because we can buy it OTC, over the counter, without a prescription, in grocery stores, Costco, gas stations, doesn't necessarily mean that it is safe. It certainly does have a maximum recommended daily dose of 4,000 milligrams in otherwise healthy adults that we should not exceed. Where does all of this data come from? Well, here in the United States, we have a couple of think tank organizations that look at all of the M&M data, that's the morbidity mortality data, and set those guardrails, those guidelines. In fact, the FDA, the Food and Drug Administration, has an analgesic advisory board that provides data and weighs in on what they believe should be the guardrails or safe maximum recommended daily doses for acetaminophen. I will share with you some new information where they may in fact be looking to reduce from 4,000 milligrams from all sources in a 24-hour period for acetaminophen. That just has not happened yet. The facts and comparison group, as well as the physician's desk reference for non-prescription drugs, there's consonance in their belief that as of today, 4,000 milligrams of acetaminophen from all sources continues to be safe. And in our patients at risk, as I mentioned, those with hepatitis, those with alcoholism or any type of liver injury, that maximum recommended daily dose should get cut in half down to 2,000. As a pharmacist, our Bible, our guiding light, our North Star, usually Goodman and Gilman. And for many years, we've always believed that the maximum recommended daily dose should probably be closer to 3,000 milligrams. And we may be getting there. In fact, if you have bought Tylenol recently, and if you've taken a look at the fine print on the packaging, you will see that labels on bottles of extra strength Tylenol in particular list a maximum daily dose as 6 pills or 3,000 milligrams. In fact, there was an Associated Press release that came out over 10 years ago showing that Tylenol lowered dosage to curb accidental overdoses. In other words, why would a for-profit pharma company, without being regulated to do so, suddenly change the labeling on their product, telling the general public to take 25% less of their medicine? And I think the right answer here is that they know their medication can be dangerous in certain patient populations, and that 4,000 milligrams per day from all sources may in fact be too much acetaminophen for many patients, leading to potential adverse events. So as I said, the Food and Drug Administration has not made that change yet, but the change could be coming. Now, this is an old slide, but it has such a great teaching point that I wanted to include it. And what this represents here, apart from the first 2 drugs listed, are what we call shotgun preparations. These are medications that have more than one active ingredient. And in this case, all of these drugs, apart from the first 2, contain some type of opioid as well as acetaminophen. So we've already talked about Tylenol, regular strength being 325 milligrams of acetaminophen, and extra strength Tylenol containing 500 milligrams of acetaminophen. But for all of these other shotgun preparations, in addition to the narcotic, you can see that they contain anywhere from 325 milligrams all the way up to 750 milligrams of acetaminophen in addition to the narcotic. Again, one of the teaching points here is that if you prescribe this perfect analgesic recipe, which contains maximum recommended daily doses of acetaminophen, that is not the day that the patient goes home and takes your prescription, but also helps themselves to some Lortab or Percocet or Tylenol 3s that they had lying around from an old knee operation. Because, it's that total amount from all sources that could suddenly exceed the maximum recommended daily dose, and the patient could really get into some trouble. Now, why is this an old slide? Well, it's an old slide because the Food and Drug Administration a few years ago actually limited the amount of acetaminophen in these shotgun preparations, these combination products, which means that if I go back to this slide, all of these numbers that you see here for the combination products have actually been changed. They no longer have this wide range. In fact, the maximum is now set at 325 milligrams for all of those products, recognizing once again that Darvocet has been taken off of the market. So for these combination medications, these shotgun preparations, and trying to limit patients' total exposure of acetaminophen from all sources, one of the recommendations from the FDA Analgesic Advisory Committee, which was taken up by the FDA, was to get pharma companies to reduce the total amount of acetaminophen in these combination products. So that was step one. In fact, the FDA Analgesic Advisory Committee made some other suggestions to the FDA, and they are encapsulated here in this table. I've highlighted one in particular, which says eliminate prescription combination products entirely. So if you recognized one of the drugs on that prior list that on occasion you may prescribe to patients, again, Percocet, Vicodin, Lortab, Lorcet, Tylenol 3s, just know that here in the United States, the FDA Analgesic Advisory Committee made the recommendation to the FDA to get rid of all of those. And you know what the FDA did? Well, you can see right there next to my arrow, they approved that. It hasn't gone into effect yet, but very soon you may not in fact be able to gain access to any of those drugs. So the best thing to do is to change your practice now before being regulated to do so. Narcotics are not anti-inflammatory agents, which means they do not address the underlying pathophysiology of dental pain, which is typically due to inflammation. So we'll talk more about this as we go along, but I think it's important to understand where the regulatory shift is going to, again, help curb this opioid epidemic by limiting the opportunity for you to prescribe certain opioids. This was that updated epidemiological evidence I promised to share with you round about acetaminophen and gastrointestinal toxicity. This was a very robust trial, 23,000 patients enrolled. They were case matched, 11,500 in each arm. And what they showed was that in patients who received acetaminophen at any dose, your relative risk of developing a peptic ulceration or bleed was about 1.3-fold over baseline. If you were taking more than 2 grams of acetaminophen a day, which is the current standard of care for anybody that suffers from rheumatoid arthritis, as well as some other inflammatory arthropathies, your chance of developing a peptic ulceration or bleed is about 3.6-fold over baseline. And if you combine that 2 grams of acetaminophen or more with a non-steroidal anti-inflammatory drug, then your chance of developing a peptic ulceration or bleed is in fact 13-fold over baseline. So for this reason, while acetaminophen may be gentler on the gastromucosa than some of our non-steroidal anti-inflammatory drugs, it's certainly not without its own pathology. I mentioned that acetaminophen is ubiquitous. It's very safe. In fact, 2021 marked the 70th year since acetaminophen was approved for use here in the United States. It continues to be the drug of choice for children with fevers, pregnant and lactating women, and in fact, it's endorsed by the American Dental Association to manage postoperative dental pain. So it seems to be a fantastic analgesic that's been around for a long time. Well, there is some very recent data that just came out, and you can see this, that despite the effectiveness and availability of this drug, acetaminophen toxicity is the most common cause of acute liver failure in both the United States and the United Kingdom. And in fact, there's some new information out there that shows that pregnant women exposed to acetaminophen, in other words, prenatal exposure, can alter fetal development, increasing the risk of some neurodevelopmental, reproductive, and urogenital disorders. Some of the latest information just published, you can see here, General Dentistry 2022. That also reminds me, by the way, and the importance of writing down my email address. If you would like any of these articles, please just email me. I'm more than happy to send you a PDF copy. In many cases, they are free downloads off of the different websites, but I'm more than happy to provide you with this primary literature. So acetaminophen will make up 1/2 of the perfect analgesic recipe that we're building towards. The other half will get made up by a non-steroidal anti-inflammatory drug, something like ibuprofen. And this is, again, one of those examples in science where dentistry leads medicine, because some of the best pain studies are actually done in dental models. In fact, the third molar extraction model is the one most often used because it's strongly validated. It's a reliable stimulus for moderate to severe pain. It's typically done in otherwise healthy young patients, so they don't have concomitant diseases. They're not on multiple medications. And the preoperative tissue tends to otherwise be very healthy. So it's an excellent model to trial different medications for their analgesic potential. Now, lots of studies out there. I'm going to credit Dr. Cooper and his group on this particular study. It's an older one from 1982, but the publication has such a nice color slide that I'd be remiss if I did not take advantage of that. So thank you to Dr. Cooper and his research team. What Dr. Cooper and his research team found in this third molar extraction model, taking a look at 5 different treatment arms. The first, of course, being the most studied drug out there in pink, which is placebo. They were even able to show that up to 4 hours after third molar extraction, even placebo had some positive effects in some of the patients treated. The green line that you see represents codeine, 60 milligrams. The same amount of codeine that's typically in 2 Tylenol 3s. And while it does look that codeine is at least twice as good as placebo, we now know that 2 times 0 is still 0. And I'll emphasize that more in a second as we start to take a look at the third line, that aqua line, which represents aspirin at 650 milligrams. The old adage of take 2 aspirin and call me in the morning shows clearly that aspirin outperforms codeine 60 milligrams at least twofold, and in fact probably even more in the third molar extraction model. Now, why am I so down on codeine as being a potential remedy for postoperative dental pain? And it's illustrated here in the purple line, which is a combination of those 2 aspirin, 650 milligrams, plus 60 milligrams of codeine. Because what do we see 4 hours after third molar extraction? That there is literally no difference made by adding codeine to aspirin. That in fact, aspirin alone is probably a much better analgesic than codeine. Who wins the day though? Well, in Dr. Cooper's study, they were clearly able to show that the non-steroidal anti-inflammatory drug ibuprofen was much more effective, certainly by the 4-hour mark, than any of the other analgesics in this trial at a dose of 400 milligrams. I mentioned that this was a study done in 1982. Subsequent studies have actually shown that the best dose for postoperative dental pain for ibuprofen is in fact 600 milligrams. And what you want to do is give that continuously. In other words, 600 milligrams of ibuprofen every 6 hours for at least 24 hours. That's good because that actually matches to the maximum recommended daily dose of ibuprofen from all sources. For acute pain, it is 2,400 milligrams. Now, in case somebody thinks that I made a mistake, while it is true you can take up to 3,200 milligrams of ibuprofen in a 24-hour period to manage pain, but that's not pain of dental origin. That's not management of acute pain. That's typically a maximum daily dose for patients that suffer chronic pain, not what we're talking about here. So please, for my dental colleagues out there, recognize that the maximum recommended daily dose of ibuprofen from all sources is 2,400 milligrams. In fact, studies show that giving between 2,400 and 3,200 milligrams of ibuprofen doesn't necessarily increase analgesia, but certainly can increase side effects. So 600 milligrams every 6 hours, giving you a total of 2,400 milligrams of ibuprofen in a 24-hour period is the maximum recommended daily dose for acute dental pain. And you don't have to take my advice for that. I am driven by medical evidence, and you can see from this recent meta-analysis, so that's the highest level of medical evidence published in the Journal of the American Dental Association, showed that non-steroidal anti-inflammatory drugs should be considered as the drugs of choice to alleviate or minimize pain of endodontic origin in situations in which non-steroidal anti-inflammatory drugs such as ibuprofen alone are not effective. The combination of an NSAID with acetaminophen is recommended. And that's really where our perfect recipe comes from. The 2 drugs that we're going to suggest as we build our story is going to be maximum recommended daily doses of acetaminophen coupled with maximum recommended daily doses of a non-steroidal anti-inflammatory drug such as ibuprofen. So how do the non-steroidal anti-inflammatory drugs work? Well, as I mentioned, pain secondary to dentistry tends to be due to inflammation. And these drugs are anti-inflammatory agents. It's right there in the name, the NSAIDs. We probably also recognize that inflammation is usually due to prostaglandins, prostanoids, are chemicals in our bodies that mediate the inflammatory response. They cause pain, inflammation, and fever. If we could reverse that, in other words, if we could block prostaglandin synthesis, we could get our patients out of pain, inflammation, and fever. And that's exactly what the non-steroidal anti-inflammatory drugs like ibuprofen do. Now, since a picture says 1,000 words, here's probably a better way to look at it. As you know, the cell membrane that makes up every cell in our bodies is combined of a phospholipid bilayer. That's illustrated in the top left here. These are the phospholipid bilayers that make up the cell membrane of every cell in our bodies. If you go below the gum line and disrupt this phospholipid bilayer, if you cause bleeding, the body is very resourceful. It's going to take those phospholipids, it's going to convert them to arachidonic acid, and then arachidonic acid is going to be converted into prostaglandins. First off, cyclooxygenase 1, one of the variants of the cyclooxygenase enzyme family, converts arachidonic acid into cytoprotective prostaglandins. You cause bleeding here, so the body, being very resourceful, takes those phospholipids, converts them into cytoprotective prostaglandins that go back up here and cause platelet aggregation. They stop that bleeding, they cause healing. These same cytoprotective prostaglandins are the ones that stop us from autodigestion. You probably remember that our gastric contents have a pH around about 2, which is very acidic. And the reason most of us don't have duodenal or gastric ulcers is because our gastrointestinal tract is lined with these cytoprotective prostaglandins. Now, arachidonic acid is also converted by a different variant of the cyclooxygenase enzyme family. This is being cyclooxygenase 2 to inflammatory prostaglandins. Remember, these are the prostaglandins that cause pain, inflammation, and fever. You go below the gum line, you cause pain, inflammation, and fever. That is essentially brought to light by the inflammatory prostaglandins. The mechanism of action of non-steroidal anti-inflammatory drugs are to block the production of prostaglandins, to block the effects of these cyclooxygenase enzymes, COX-1 and COX-2. When they do that, they get your patients out of pain, inflammation, and fever, which is fantastic. If you think about the side effects of these drugs, though, do they cause increased bleeding and decreased wound healing postoperatively? They do, because they stop the production of prostaglandins that promote platelet aggregation. And for those patients at risk of gastroduodenal ulcers or peptic ulcerations and bleeds secondary to non-steroidal anti-inflammatory drug use, it's obvious that that's due to the fact that we, again, stop the production of prostaglandins that are cytoprotective to our GI mucosa. So the nice part is that the benefits in most cases outweigh the risks here. But if you're wondering why non-steroidal anti-inflammatory drugs have certain side effects, it's as an extension of their mechanism of action. Now, similar to acetaminophen, many of our non-steroidal anti-inflammatory drugs can be purchased over the counter, OTC, without a prescription. In fact, because of that, you can go to Costco, Walgreens, Walmart, and buy a pound bottle of ibuprofen without a prescription. And we get lulled into this false sense of security, similar to acetaminophen, that because these drugs can be purchased without a prescription over the counter, that they must be safe. Well, I would bring your attention to this, although it's getting older, it's still pertinent, article from the New England Journal of Medicine, which showed that non-steroidal anti-inflammatory drugs killed as many patients as AIDS did in 1997, which really should start to drive home the fact that even though these drugs can be purchased OTC, it doesn't necessarily mean that they're safe. Similar to our good old friend acetaminophen, they definitely have maximum recommended daily doses that you do not want to exceed. In fact, when we start to talk about how long can we safely treat patients with non-steroidal anti-inflammatory drugs, that work was recently done and published again as a systematic review in the Journal of the American Dental Association. And you can see that the use of non-steroidal anti-inflammatory drugs can be considered relatively safe when prescribed at the most effective dose and for the shortest duration of time, which was less than 10 days. So knowing that you can safely prescribe these in most healthy adults for up to 10 days, that's a great safety net, because really what we need to do is prescribe these for 1 to maybe 3 days. But if a patient is still having significant pain, despite a combination of maximum daily dose of acetaminophen and ibuprofen after 2 to 3 days, they need to come back and see you because something else is going on. These non-steroidal anti-inflammatory drugs do certainly carry some risk, as we've seen, due to their mechanism of action. In fact, you and I, leading our semi-stressful lives, have a chance of developing a peptic ulceration or bleed about a rate of 0.2% per year if we're not using non-steroidal anti-inflammatory drugs. The risk is higher in men than in women, but if you compound that with taking chronic non-steroidal anti-inflammatory drugs, you can certainly increase the risk of developing peptic ulcerations and bleeds anywhere from 2.5 to 8-fold. Now, that brings up this other most recent publication that shows that not all non-steroidal anti-inflammatory drugs are created equally. In fact, it is a continuum. The least ulcerogenic of all the non-steroidal anti-inflammatory drugs is good old ibuprofen, which is why we're going to suggest that ibuprofen make up the second half of the perfect analgesic recipe. At the other end of the spectrum, you have ketorolac. Many of you know ketorolac as Toradol. It is the most ulcerogenic of all the non-steroidal anti-inflammatory drugs. In fact, ketorolac has a black box warning that says, "Dear doctor, if you are going to prescribe ketorolac for your patient, they cannot take it for more than 5 consecutive days. This drug is highly ulcerogenic." So if the oath that we all took upon graduation was to first do no harm, we want to give our patients the safest non-steroidal anti-inflammatory drug, which in this case shows to be ibuprofen. Again, the non-steroidal anti-inflammatory drug with the lowest toxicity, and we're going to prescribe the most effective dose for the shortest period of time. To drive this point home, when I was practicing at the Kootenay Lake General Hospital in Nelson, British Columbia, one summer I worked with our internist, and we brought in some students from Selkirk College, young, healthy kids, and we gave them maximum daily doses of ketoprofen for 30 days. What you're looking at is a picture shot through an endoscope just above the lower esophageal sphincter that in this one student showed that even after just 7 days of maximum recommended daily doses of a non-steroidal anti-inflammatory drug, you were able to develop some petechiae, some redness, and certainly some swelling in the gastrointestinal mucosa. At the end of the study, again, in a different subject this time, when we scoped them, you could see that there's now some petechiae, some redness, and even some overt bleeding, even some areas of necrosis. And that's just after a single month of maximum recommended daily doses of non-steroidal anti-inflammatory drugs. Doses, by the way, of medications that, again, your parents or grandparents that have rheumatoid arthritis may have been taking for years. So what could be going on in their GI system? So recognize that these drugs do have maximum daily doses that you do not want to exceed. As you can see here for ibuprofen, 2,400 milligrams per 24 hours for the management of acute pain. And then just that, again, footnote that even though there is a higher MRD, that's typically for these inflammatory arthropathies or chronic pain. If you prefer to use diclofenac, naproxen, any of the other non-steroidal anti-inflammatory drugs, perfectly fine. Just stay within the guardrails. Recognize that they do have maximum recommended daily doses that you do not want to exceed. So this is that perfect prescription that we've been talking about, and it's on page 5 in your handout. We've actually created a mnemonic that makes it very easy to remember. The perfect prescription for post-operative analgesics are the numbers 2, 4, 24, which stands for 2 drugs, 4 doses for 24 hours. You've now learned those 2 drugs are maximum recommended daily doses of ibuprofen, so 600 milligrams every 6 hours for 24 hours, coupled with maximum daily dose of acetaminophen. That would be 2 extra strength Tylenol or 1,000 milligrams, also given every 6 hours for 24 hours. Now, this is not my opinion. You can see there's the original resource, which we published in the Journal of General Dentistry a few years back. And then the specialists, Dan Becker and his group in Anesthesia Progress, came up with the same conclusion about a year later. And then even Gori Christensen in his periodical promoted this combination as being the perfect analgesic recipe for post-operative dental pain. But I'm going to pause here because, you know, what makes this successful? And there's a couple things. We need to set our patients up for success. In other words, if it's legal in your province or state to provide these non-prescription medications to the patient from your office, I would suggest you do that. But why would we make our patients go from your office to the pharmacy to home? In some cases, they may not necessarily make that interim trip, which means that they don't have the analgesics they need to keep them out of pain. So if you are interested in setting your patients up for success, you can go and get some of those little medicine reminders. You can go to Costco or one of the big box stores, get a large supply of extra strength Tylenol, a large supply of 200 milligram, the non-prescription strength of ibuprofen, and spend a weekend making these little compliance packs that you give to your patients. In fact, if you want to set your patients up for success, they should take the first dose of these drugs in the office. Now they are only responsible for 3 more doses. But what makes this combination work is compliance. In other words, if a patient has a dose due at 2 in the morning, they need to set their alarm, wake up at 2 in the morning, take their medication, and go back to bed. They do need to take 2 drugs, 4 doses, in other words, every 6 hours for at least 24 hours. I sometimes get the question, well, Mark, can we stagger the doses? And the short answer is, yeah, absolutely you can, but there is no pharmacological reason to do that. In that case, the strategy would be giving 1,000 milligrams of acetaminophen now, 3 hours later, 600 milligrams of ibuprofen, 3 hours later, another 1,000 milligrams of acetaminophen, 3 hours later. And you can see that that tends to be a little bit of a burden on the patient. But if you have patients, and you know who they are, they're called clock watchers, where they just sit there and after 3, 4, 5 hours, they just don't think that they can stand it anymore. They know they're going to be in pain. Sure, for those patients, if you want to suggest a staggered approach, that would be perfectly fine. But just recognize that there's no pharmacological reason to stagger the doses of those particular medications. Again, I think setting our patients up for success is important, and also making them understand that this is, in some cases, new data. Most of our patients have had acetaminophen. Most of our patients have had ibuprofen. But you do have to sell a little bit, which is there is new data out there showing that maximum recommended daily doses of these drugs in combination is one of the most powerful analgesic recipes that we have. So, John, I know you're a special patient, and I know that historically I would write for Darvocet or Percocet or Tylenol 3s for you, but based on this new information, I want you to trust me on this. I know you've had ibuprofen and acetaminophen in the past, but have you ever taken maximum recommended daily dose of both of those drugs together every 6 hours for 24 hours? If you promise to do that for me, if you promise to be compliant, in fact, since you are a special patient, if you promise to do that for 48 hours, don't miss a single dose, and your pain is not markedly improved within 24 to 48 hours, sure, call me, come back to the office, and we'll talk about other strategies. But if you guarantee that you will be compliant with these 2 drugs, 4 doses for at least 24 hours, I can almost guarantee that you will be out of pain. And this recipe does work for greater than 90% of all of our patients, but is based on compliance. We do have other options, though. That perfect analgesic recipe may only be, option number 1, because as many of you would probably attest to, that may not work in all of your patients. Maybe you have different patients. So let me give you some additional strategies. You may have heard of the COX-2 inhibitors, the cyclooxygenase 2 inhibitors, which were supposed to offer all of the same benefits of our traditional non-steroidal anti-inflammatory drugs without the potential side effects. In other words, they would block the production of inflammatory prostaglandins while allowing for the production of cytoprotective prostaglandins. We used to have, past tense, 3 of these drugs on the market, Vioxx, Bextra, and celecoxib. But Vioxx and Bextra have been removed for different reasons from the American Pharmacopoeia, and at this time we really only have Celebrex as a pure cyclooxygenase 2 inhibitor. Again, I know that's a lot of verbiage, so since a picture tells 1,000 words, essentially this is how these cyclooxygenase 2 inhibitors work. They only block 1/2 of the equation. They stop the production of prostaglandins that mediate pain, inflammation, and fever, while allowing for the production of cytoprotective prostaglandins that are going to go cause healing in this area and continue to protect our GI mucosa from peptic ulcerations and bleeds. Now, if I was to name these prostaglandins, so I'm going to change the slide slightly. The cytoprotective prostaglandins are also known as thromboxane A2, and the inflammatory prostaglandins are known as prostaglandin E2 and I2. Now, nature loves balance, and that's exactly why we have sort of a balanced scale here. And unfortunately, the reason that Vioxx was removed from the market as a COX-2 inhibitor was because it greatly upset this balance. In other words, it stopped the production of these inflammatory prostaglandins, allowing for the overproduction of these cytoprotective prostaglandins. And why is that a big deal? Well, prostaglandin I2 is predominantly found in the endothelium, and it inhibits platelet aggregation. It causes vasodilation, prevents proliferation of vascular smooth muscle cells. In other words, it stops us from dying from sudden cardiac death. If you give a COX-2 inhibitor, certainly something as powerful as Vioxx, you stop the production of prostaglandin I2, which allows for the overproduction of thromboxane A2, which does the opposite. It is a major product of platelets, which causes platelet aggregation, vasoconstriction, vascular proliferation, in other words, sudden cardiac death. And in the ADHERE trial that Vioxx was involved in, several of our patients unfortunately died of sudden cardiac death because of this upsetting of the balance. So if I was to poll you, and you were honest, and I asked how many cyclooxygenase 2 inhibitors do we currently have, I'm sure most of you that have been following along would say, well, one. At least in the United States, it looks like Celebrex is the only one that's left. And I always hated it when my professors asked me questions like that because it was always a bit of a trick. In fact, we have many cyclooxygenase 2 inhibitors. Don't forget that non-steroidal anti-inflammatory drugs all block cyclooxygenase 2, but they also block cyclooxygenase 1. In fact, again, it's a continuum. At one end of the spectrum, you have ketorolac, also known as Toradol, that non-steroidal anti-inflammatory drug that has that black box warning. Dear doctor, this is the most ulcerogenic of all non-steroidal anti-inflammatory drugs, and you cannot give it to a patient for more than 5 days. And at the other end of the spectrum, you have Vioxx, also known as rofecoxib, which was removed from the formulary because it primarily blocks cyclooxygenase 2 and not much blockage of cyclooxygenase 1, therefore really upsetting that balance. Once again, if the oath that we all took upon graduation was to first do no harm, we want to pick the safest analgesic, which is going to be right in the middle, and that again is going to be our good friend ibuprofen, a nice balance in the mix in blocking both cyclooxygenase 1 and cyclooxygenase 2. Since Vioxx has been removed from the market, and we really do only have Celebrex as the only pure COX-2 inhibitor, you can see that bringing economics into the equation, a week's supply of ibuprofen costs about $2, where a week's supply of Celebrex costs almost $75. Obviously, that's going to vary country by country, but I think the point here is taken that good old ibuprofen does the same job as Celebrex at a price point that is much more palatable. So is there still a role for Celebrex? Well, in fact, there may be. And the suggestion I'll first off make, if cost is not an issue, then maybe Celebrex is a better drug. If your patient is controlled on a blood thinner or an anticoagulant such as warfarin, also known as Coumadin, then maybe the Celebrex is a better choice to avoid that hypoprothrombanemic effect and drug interaction between our non-steroidal anti-inflammatory drugs and the anticoagulant. Outside of those two indications, though, really ibuprofen is at least as good as Celebrex. However, if the original perfect prescription that we talked about, the 2424, is not going to be enough for your patient, then a third option for utilizing Celebrex is as preemptive analgesia, also known as giving preoperative analgesia. So the philosophy here is, again, looking at our perfect prescription, and rather than waiting until our patients are in pain, what if we gave something upfront, preemptive analgesia, that mitigated the inflammatory response such that the post-operative analgesic requirements was actually less? And that's exactly the strategy that is typically used with giving Celebrex 30 minutes prior to dentistry. Now, this data actually comes from the orthopedic literature. When we do very large orthopedic, very painful surgeries, such as total knees, total hips, even total shoulders, we will typically give 400 milligrams of Celebrex 30 minutes prior to wheeling the patient to the OR. And we have found that the post-operative analgesic requirement in these orthopedic patients is much reduced. So there is a growing body of evidence in support of doing this also in dentistry. And again, we use Celebrex preemptively because of its effect on providing good post-operative wound healing and decreased bleeding post-operatively as compared to our non-steroidal anti-inflammatory drugs. So that may be a consideration in some of your patients in whom you believe the 2-4-24, the basic perfect prescription, may not necessarily work. But let's give you another tool in your toolkit. Many of you may not be aware of this drug and some new data out there, which again, the highest level of medical evidence, a systematic analysis, showed that as a single one-time intraoperative dose of dexamethasone up to 10 milligrams, you can eliminate early and late edema as well as trismus after third molar extraction. So fantastic. And this is one of those sort of final tools in your toolkit that really sort of seals the deal in managing your patients postoperatively and keeping those patients out of pain. So ultimately, the addition of a single intraoperative dose of dexamethasone up to 10 milligrams may change our perfect prescription from 2-4-24 to a mnemonic of 1-2-4-24. Now, you could give dexamethasone orally. It comes as 4 milligram tablets, and you could give 4 to 8 milligrams preemptively with or without the Celebrex. You could give those tablets post-operatively, let's say 4 to 8 milligrams twice a day for 24 to 48 hours. But as a single one-time intraoperative dose up to 10 milligrams, where you don't have to rely on patient compliance preoperatively or postoperatively taking the tablets, why would you not take that opportunity to set your patients up for success? Historically, many of you may be familiar with dexamethasone or some of the other glucocorticoids being available in compliance packs that patients were given postoperatively to help manage postoperative dental pain. Here is an example of a methylprednisolone dose pack, also known as a Medrol dose pack. And these dosage packages were usually a tapering dose. So in the case of these 4 milligram methylprednisolone tablets, patients would take 6 tablets on day 1. The next day they would take 5 tablets. The next day they would take 4 tablets. The next day they would take nothing. They would throw the rest away because they can't get off the toilet and they're having to call in sick because they're having such significant GI irritation. There's a couple of things here. First of all, this is a marketing gimmick. Unless you were providing exogenous glucocorticoids greater than 14 days in a row, it takes 14 days to suppress the hypopituitary axis, requiring tapering of steroids. So if you're only going to be giving steroids for 4, 5, 6 days, certainly less than 14 days, you do not need to taper them. The second teaching point is that these very large heroic doses of glucocorticoids up front, so initially 24 milligrams, and then 20 milligrams, and then 16 milligrams, those large upfront doses are very irritating to the gastrointestinal system. And as I said, the patients will try to be good patients, they'll try to be compliant, but after 2 or 3 days of taking these high-dose glucocorticoids, the gastrointolerance is going to potentially lead to them calling in sick, not being able to get off the toilet, and throwing away the rest of the drugs. Now, if this is news to you, it's because patients are too embarrassed to tell you this. The next time you see that patient, John, how'd the appointment go? How did that postoperative analgesic go? Went great, doc. Everything worked out okay? Yeah, perfect. Oh, great. Then I'll give you the same thing. You know what? I'll take the ibuprofen and acetaminophen, but I don't really think I need those steroids anymore, doc. So that's part of the reason why, as a marketing gimmick more than a clinically applicable dose, we really don't see Medrol dose packs anymore. Now, not to be outdone, of course, there was the Dex packs in a 6, 10, and 13-day formulation. But again, these tapered formulations are not required, as it does take 14 days of exogenously applied glucocorticoids to suppress the hypopituitary axis. So these are not good dosage forms either. And they all tend to be very expensive. So why dexamethasone in particular? Well, because it has a very long half-life. You can see that the plasma half-life here exceeds almost all other glucocorticoids. And if you were going to give it as a one-time intraoperative dose up to 10 milligrams, from many studies, we can see that you actually get a very prolonged effect. Dexamethasone comes as tablets, it comes as an injection, it comes as an elixir. But from this one particular study, you can see that that one-time intraoperative injection of up to 10 milligrams actually gives you almost 6 days of analgesia, especially when combined with our 2-4-24 perfect prescription. And so this is that last piece of the puzzle. Our endodontic colleagues have been using glucocorticoids postoperatively for years. It's only recently that GPs and other specialists are now starting to recognize the value of providing glucocorticoids, especially dexamethasone, as a one-time intraocular injection up to intraoral injection, up to 10 milligrams. That they're recognizing the benefit of these drugs. Now, what would I recommend? Well, the teaching point from this slide is that dexamethasone as an injection comes in many concentrations. The low concentration of 4 milligrams per milliliter, the middle of the road 10 milligrams per milliliter, and then the high strength of 20 milligrams per milliliter. And the teaching point here is just to stick with a single concentration, especially if you are not the one that does the buying in your office. You want to make sure that the same concentration is the one that's being used all the time. And part of the reason for that is in our busy lives, we don't necessarily think about injectable medications in terms of milligrams. We usually think about them in terms of milliliters. Now, if you were to think about the most common type of injection that dentists give, which are usually local anesthetics, that's about 2 milliliters of liquid. I get it, it's usually 1.7 or 1.8, but about 2 milliliters of liquid. So if you are used to injecting 2 milliliters of liquid, then you want to buy the middle of the road concentration, 10 milligrams per milliliter, and you would be giving half of that. Alternatively, buy the low concentration, 4 milligrams per milliliter, because 2 milliliters of that is going to be 8 milligrams, and that's still a safe dose. If you're not the buyer, though, and one day the buyer finds that one of the higher concentrations is less expensive, and that's what they purchase, and you're always used to giving 1 milliliter or 2 milliliters, depending on the concentration that you typically stock, if that concentration has changed, suddenly you could be giving a much higher dose. And then patients could feel ill effects from that, such as tissue sloughing and possible tissue necrosis. The injection is very simple. We're talking about a small amount of liquid, so usually a tuberculin or insulin syringe, and given exactly as an infiltration injection. It does not necessarily have to be in the quadrant that you're working in, but of course, if the patient's already numb there, then that makes the most amount of sense to give the injection there. I do have some of your colleagues who split the dose up. If they're working in 2 quadrants, they'll give an injection in both quadrants. Really not necessary. This is a systemic effect, so a singular injection is all that's really required. And again, you get up to 6 days of postoperative analgesia in your patients. If you remember back to dental school and your pharmacology classes, you probably remember that there are all these potential side effects of glucocorticoids, whether they're absolute or relative contraindications. And it was the bane of all of our existence, is having to memorize all of these. The nice thing is that because you are giving a single one-time intraoperative dose of dexamethasone up to 10 milligrams, you can forget all of this. There is literally no patient population that cannot receive a single one-time intraoperative dose of dexamethasone safely. So our 2-4-24 perfect prescription may look more like 1-2-4-24, where again, that 1 represents that singular intraoperative dose of dexamethasone. Now, I do live in the same real world as you guys. And because of that, I'm always hesitant to sit here and say there's nobody that can't receive dexamethasone safely. So I scoured the literature. And certainly there is one potential patient population in whom you don't want to give dexamethasone to, and that may be a patient that's suffering an active GI bleed. If a patient is suffering an active GI bleed, I can tell you that dentistry is not their most immediate concern. They're going to be in my emergency department, where we're going to be giving them octreotide and trying to clamp those bleeds because they're coughing up so much blood. So again, I guess it is possible to have a patient population who shouldn't receive it, but these are not patients that you're ever going to see in a dental office. So what does the perfect prescription look like? We started off with 2-4-24. We gave you some additional options with a preemptive dose of Celebrex. maybe combining that even with a single one-time intraoperative dose of dexamethasone up to 10 milligrams. But this last opportunity is something I know people are already taking advantage of, and that's a long-acting local anesthetic like bupivacaine or etidicane, just prior to discharging the patient and starting them on their oral medications. That allows for the local anesthesia to have some additional impact while the oral analgesics begin to take over. Now, after 75 years, it's hard to believe it's lidocaine's 75th birthday this year. After 75 years, is there really anything new about local anesthetics that I can impart to you? Well, it's possible that there is, not just the fact that long-acting local anesthetics given right before discharging a patient from your office may add to appropriate postoperative analgesia, but in fact, a new local anesthetic out there, or at least a new formulation of an old anesthetic, has been released on the market, and that is known as Exparel. In other words, liposomal bupivacaine. It's been available now in the United States in medical circles since 2011, so maybe not as new as a lot of people would think, but perhaps new to dentistry. Please bear in mind, though, that the two clinical trials that brought Exparel to market were done in bunionectomy and hemorrhoidectomy patients, not dental studies. And one of the benefits that they found in these very painful type surgeries was that when injected intraoperatively, Exparel could in fact provide up to 96 hours of local anesthesia, local pain relief for these patients. So in medicine, this has been seen as a triumph. But we have also seen some challenges. In other words, if a patient has an untoward reaction to Exparel, there's no specific reversal agent. Oftentimes, those patients need to be readmitted, and we will try to support them for up to 96 hours as the drug wears off. So sometimes too much of a good thing can be too much. What's very interesting from a legal aspect, if you will, is Exparel was the very first analgesic to receive labeling by the FDA as a non-opioid long-acting analgesic. So it was the first in class. And given the backdrop of the opioid epidemic, which we started off talking about, this was purposefully labeled as a non-opioid long-acting analgesic. Now, I think the same could be said for acetaminophen, or ibuprofen. But because of this new labeling, because of the opioid crisis, because of heavy marketing, Exparel suddenly started to take off. And where did it take off? Well, unfortunately, it started to make inroads into dentistry. Dentists are experts at local anesthesia. And so if you had a new form of bupivacaine, a drug that you're very familiar with that lasts 96 hours, maybe it could also be useful in dentistry. Well, the challenge, and I don't want to make this all about money, is that your typical cartridge of bupivacaine probably costs $2 or $3, whereas an ampule or vial of Exparel costs close to $400. And so that certainly does add a lot more expense to the case. But again, I don't want to make it all about the money. There are some safety concerns as well as efficacy concerns. The first off is if you do use Exparel, you are not allowed to use any other local anesthetic around about that same time. So that starts to really limit the way that you manage patients, and ultimately says that if you're going to use Exparel, it may be the only local anesthetic you can use in certain patients. It's also not approved for block anesthesia. Now, there are some of your colleagues, and I've quoted one here in a recent advertisement in a journal that came out. This dentist said that by limiting the number of prescriptions available to patients, by simply providing Exparel intraoperatively to them, I can help serve the effort of curbing opioid abuse. And that may be a misinterpretation, because those bunionectomy and hemorrhoidectomy trials that brought Exparel to market didn't actually show a decrease in narcotic requirements postoperatively for those patients. The only thing Exparel was actually able to show was a decrease in postoperative days in the hospital. Patients still, in general, receive just as much narcotic postoperatively. And again, I would be remiss if I didn't remind you of the significant delta in cost between Exparel, liposomal bupivacaine, and traditional bupivacaine, which you currently utilize. So it brings up the question, and in fact, the publication that says, does liposomal bupivacaine fulfill an unmet need in dentistry? And from these two authors, as well as many more in the dental profession, the clear answer is no. And in fact, in medicine, we now also recognize, and you can see this systematic review published in Anesthesiology, comparing ex-spiral liposomal bupivacaine to traditional plain bupivacaine, that liposomal bupivacaine was not found to be different from plain local anesthetics for postoperative pain and all other analgesic and functional outcomes. So while it did seem to have an important role early on because of how it was marketed, most hospitals are now removing ex-spiral from their formularies because it's really just a budget buster. And traditional plain local anesthetics seem to be as effective and perhaps safer. So with all of that, I wanted to close our evening talking about opioids, because there may be some of you out there who still think that your patients, despite the 1, 2, 4, 24 and long-acting local anesthetic, may still be candidates for an opioid. And if that is resonating with you, well, I just want you to understand exactly how they work and how to prescribe or use them. First of all, remember that pain secondary to dentistry is due to inflammation, and these drugs are not anti-inflammatory drugs. They do not affect the underlying pathophysiology of dental pain. Patients still have pain, they just don't care as much about it because those drugs work centrally here to cloud the sensorium. They don't actually work here where the patient has pain. When we take a look at current addiction rates, 1 in 17 people started on an opioid will become addicted. And I'm not certain that you want to be that prescriber that gives that one patient that gateway medication. The risk for substance use disorders and bad outcomes associated with substance use is highest in our teenagers, those patients in whom we may be doing third molar extractions and may be the ones exposing them to narcotics for the first time. Part of the reason that this is the fastest growing faction in our population of opioid abusers and patients suffering substance use disorders is because the plasticity of the brain does not actually complete until about the age of 25. So these patients' brains are still immature to a certain degree and can be negatively impacted during the maturity process by introducing them to these narcotics. What are some of the common risk factors that add to this? Well, patients that have a history of substance abuse, if they have mental or behavioral health conditions, as you see listed here, to include attention deficit disorder or the ADHD. If they have impulsive risk-taking behavior, a history of traumatic events, or even just low self-esteem or feelings of social rejection, which feels to me like I'm describing almost every teenage angst. That they tend to be the ones that are most susceptible to the bad effects of these drugs. And of course, there are some negative consequences of introducing our teens to these drugs, not just drug dependence, but certainly they can influence the overall judgment, can lead to improper sexual activity, leading to increase in teen pregnancy rates, mental health disorders, impaired driving, and certainly changes in school performance. So we don't want to make a bad situation worse. And recognizing this high-risk population, really these are the ones that you want to most avoid introducing narcotics or opioid-containing analgesics. If you are going to utilize opioids, please recognize, and I've given you this table on page 8, that we have what are called equianalgesic dosing charts. In other words, if you have patients that are currently controlled on opioids, and therefore you think that you want to give them an opioid postoperatively because they're used to having opioids in their system, recognize that the opioid you prescribe may or may not be enough to help them with their additional acute on chronic pain. So an example here could be codeine. Let's say you typically prescribe 2 Tylenol 3s. Each Tylenol 3 contains 30 milligrams of codeine, so that would be 60 milligrams of codeine. If a patient comes into your office and they're already taking, let's say, 80 milligrams of Dilaudid for cancer pain, and you decide, well, rather than the 2-4-24, I'm going to go big and give them 2 Tylenol 3s every 4 to 6 hours, know that 80 milligrams of oral hydromorphone is about the same as 1,800 milligrams of codeine orally. And so giving them 60 milligrams is really just blowing in their ear. They have a much higher tolerance for opioids. Now, that may be an extreme example, so I want to give you probably a much more clinically applicable example. Tylenol 3, we've talked about it a number of times, contains 300 milligrams of acetaminophen and 30 milligrams of codeine, which means that if the FDA Analgesic Advisory Committee is successful in their suggestion to the FDA that we need to get rid of shotgun preparations, and you routinely prescribe Tylenol 3s and no longer can, that's okay, because 2 Tylenol 3s are the same as 10 milligrams of morphine. So if you can't prescribe Tylenol 3 anymore, you just simply prescribe 10 milligrams of morphine. And when I say it like that, that feels a lot different. I mean, you want to give them a drug, but I mean, morphine's a real drug, a real narcotic. Well, in fact, Tylenol 3s are the exact same as morphine. They're just packaged slightly differently with a different name. Similarly, 1 Vicodin contains 325 milligrams of acetaminophen as well as 5 milligrams of hydrocodone, which means that 2 Vicodin are the same as 10 milligrams of oral morphine. If Vicodin is pulled from the market and you still want to prescribe narcotics, that's fine. That's why we have morphine. So when I sort of arrange the conversation that way, it feels a lot different. And hopefully that alone is enough to discourage you from prescribing opioid-containing analgesics. Recognize too that these drugs have not only some good effects, they are drugs of abuse, but they also have some bad effects. And in our older population in particular, a single one-time dose of any type of opioid is enough to affect their regular constitution. So the 11th commandment tends to be the hand that writes the narcotic order should also write the laxative order. You definitely want to encourage your patients, if you are going to write for opioids or narcotic-containing analgesics, to increase their fluid and fiber intake and even perhaps co-prescribe a stimulant laxative. There are definitely patient populations that should never be exposed to opioids. And I've given you the hot list here of those with a history of sleep apnea, obesity, certainly those with Pickwickian syndrome or short neck syndrome with a lot of redundant soft tissue, anxiety or depression, and fibromyalgia. These are patients that we certainly want to involve our medical colleagues if we are really thinking about prescribing opioid-containing analgesics postoperatively. And if you are going to prescribe opioids, oftentimes the question is raised, well, how much should I give? Is there a safe amount? Well, again, recognize that with a 10-day initial opioid prescription, about 1 in 5 patients becomes a long-term user. So certainly 10 days is probably far too much, especially if patients are still having significant pain after 24 or 48 hours. They really should come back and see you. You should not be writing for opioid-containing analgesics for 10 days. After just 5 days, however, of prescription opioid use, the likelihood of developing long-term dependence on these drugs rises steeply, increasing the risk of eventual addiction and overdose. So maybe even 5 days is too much. However, there's also data to show that even patients that get an initial 1-day opioid prescription have about a 6% chance of being on opioids for a year or longer. So what is the right answer? Well, again, we default to the regulatory bodies that have actually weighed in on this. You can see from this regulatory example very clearly, if the dentist prescribes opioids for effective pain control, such a prescription must not be in greater quantity than needed and certainly should not exceed a 14-day supply. I actually think that that's fairly generous, as we've seen from some of those statistics, but in that one state, up to 14 days is deemed to be okay. What does the ADA, the American Dental Association, say on this topic? Well, they fall more in line with the Center for Disease Control, saying that dentists should never prescribe more than a 7-day supply of opioid-containing narcotics for postoperative dental pain. But again, we keep bringing back the idea, what is the right answer? And should the right answer actually be measured in days? Perhaps it should be measured in units of narcotics. So if you're familiar with some of the most recent legal data that's out there, there have been several cases of physicians as well as oral healthcare professionals being incarcerated for manslaughter. And the argument has been that they essentially put a loaded gun into the patient's hand by prescribing large doses of opioids, in which the patient took all of them, not as recommended, but took all of them in a suicide attempt that was successful. And it was deemed that that suicide was in fact made possible by the overprescribing of opioids. So Dr. Jason Goodchild and myself got together one year, and we said, you know what, based on all of the currently available opioids in the United States, and based on current M&M data, that's morbidity and mortality data from the Food and Drug Administration, could we come to a consensus as to the safe number of units of any narcotic-containing opioid that a dentist could prescribe, and know that if a patient took all of those doses at once, it was not going to be enough to cause death. And in fact, that number is 12. So again, this is a peer-reviewed literature citation. If you would like the article, feel free to email me and I'm happy to send you a copy. But essentially know that if you do want to prescribe opioids postoperatively, don't think about a 2, 3, 5, 10, 14-day supply. Just know that if you give up to 12 units of any of the currently available narcotic-containing opioids, that you at least give your patients a chance. And the chance of them dying from a potential suicide attempt is going to be mitigated. Lastly, I talked about the prescription drug monitoring programs, which are being endorsed by most boards of dentistry here in the United States and most colleges in Canada. And here's just one example of how you can access through your board for health website. In California, you're well aware that the CURES program, the Controlled Substances Utilization Review and Evaluation System, also known as a PDMP or Prescription Drug Monitoring Program, is a requirement. If you're a licensed dentist in California, you have to be registered and you have to access this prior to prescribing any controlled substance, such as a narcotic-containing opioid analgesic. Not to be outdone, other states have followed suit. And here's just another example of a state where the regulatory body says that the dentist shall register with the PMP, and at a minimum, the dentist shall ensure that a PMP query is performed prior to prescription of any opioid. So the regulatory bodies are getting involved, as well as our guiding authority, the American Dental Association here in the United States, which clearly says that the ADA supports improving the quality, integrity, and interoperability of state prescription drug monitoring programs. That's been in place since 2018, which is why almost every state in the nation now has a PDMP, and almost every dental board requires dentists to access that before they think about prescribing a controlled substance for a patient. Which brings us to my final topic, and that is the co-prescribing of naloxone. This is something, if you're not aware, some dental boards and even colleges in Canada are requiring. In other words, the hand that writes the narcotic order must also write the naloxone order. And so this is just, again, one example of the co-prescription of naloxone anytime an oral healthcare provider writes a prescription for an opioid. This becomes a little bit of a challenge because now you're giving a patient two prescriptions, and the public-friendly formulation of naloxone is in fact quite expensive. In the hospital or the EMTs, we can inject drugs, and that's usually the cheapest and easiest way to go with naloxone. To avoid needle sticks, oftentimes what our EMTs will do is they will draw up the injectable form, remove the needle, attach a mucosal atomization device, and give the injectable as almost an Afrin nose spray intranasally. So that's handy. But we can't be sure that the general public will be able to do those manipulations. And so you can see in the bottom left that there is in fact a Narcan nasal spray. Now this Narcan nasal spray has been available for a few years. It's sort of the public-friendly or non-healthcare provider-friendly way to administer naloxone to a patient who may experience over sedation with narcotics. But you can see that the average wholesale price is about $150. So every time you want to prescribe up to 12 units safely of an opioid-containing analgesic, you are also perhaps going to have to give the patient a prescription that's going to cost them an additional $150. Now, there is an auto-injector available that recently came to market known as Evzio, so working very similar to an EpiPen or some of those auto-injectors we're familiar with. Rather than patients having to take that intranasal or inject, they could use this Evzio, this one-time injection, which can be done through clothing. Unfortunately, costs over $2,400, so very, very expensive. So this is that last slide that I mentioned right at the very beginning. Questions roundabout dental authorities and regulatory bodies as to, based on the opioid epidemic, should dentists keep naloxone in their emergency kit? And the short answer is actually yes. You can see that one of the gurus in emergency dental medicine, Stan Malamed, co-authored this, and in fact endorses the fact that dentists should be carrying naloxone. Now, it's not because you use narcotics and hopefully are not prescribing narcotics post-operatively, but when you consider the depth of the opioid epidemic and the fact that greater than 50% of our general population has some measure of fear or anxiety about going to the dentist, some of our patients may, take a little bit of Lortab or Percocet or some illicit narcotic to take the edge off or help them relax prior to coming to dentistry. And if you're a sedation dentist that's providing some type of oral sedative to get your high fear patients to relax, if that patient didn't tell you they took some type of narcotic or opioid, the combination of your oral sedative and that can put them into a deeper level of sedation than you intend. Obviously, the first thing you're going to do is want to reverse the sedative you gave them. So you'll give them something like flumazenil, the reversal agent for benzodiazepines. But if nothing happens, the next thing you probably want to do is call 911. And then finally, the third thing, while you're waiting for the EMTs to arrive, is probably administer naloxone, because the reason that patient went out wasn't necessarily due to your sedative alone, but the fact that they took either illicit or illicit opioid prior to coming to the dental office. So having naloxone in your emergency kit probably makes good sense. Hopefully, I've helped you manage and create an opportunity for getting your patients out of pain post-operatively. This says, Dear Santa, if you leave a new bike under the tree, I will give you the antidote to the poison I put in the milk. You definitely have to start early to become a pharmacist. I committed to you my email address at the beginning. I'll do so on the next slide, but I would be remiss if I didn't again congratulate Premier on their 110th birthday and thank them for supporting this continuing education as well as many others. Here again is my email address. And with that, I know that we've left some time here for questions and answers. Thank you.